Please be advised that there is a potential trigger alert with this presentation. We're going to be discussing some really tough topics, and many of us have experienced adverse childhood events, and so potentially we will get emotionally distressed. Please exercise self-care. Mute this presentation if you have to. Step out of the room if you have to. Please take care of yourselves. So what is trauma? Trauma consists of intense and overwhelming experiences that involve serious loss, threat, or harm to a person's physical and or emotional well-being. It may occur at any time in a person's life. It may be just one large traumatic event, or it may be multiple traumatic events over the course of many years. Often, trauma experiences will overwhelm our coping resources, and we may engage in harmful activities in the short term that may help us feel better, but then they're detrimental in the long term for us. So these are all potentially traumatic events. There can be psychological trauma, physical, sexual abuse. These are the kind of traumas that we are used to hearing when we talk about adverse childhood experiences, but there's so many more things that can happen in a child's life, including the sudden loss of a loved one. There can be neglect in their life, or witnessing or experiencing domestic violence. And we all have seen the images of Afghanistan, Ukraine. We're living some shared traumas. We all, for those of us who are old enough, experienced 9/11 together, and let's not forget 2 years of COVID. So what is the ACE study? So the ACE study was a 10-question measurement done back in 1995 to 1997. It involved 17,000 adult participants. That's a huge study. It was a collaboration between the Centers for Disease Control and Kaiser Permanente. So Kaiser Permanente, for those of you who are not familiar, is a large California health system. It's a one-stop shop for all things healthcare. Now, these results are still being tracked today, and it has generated more than 100 papers and articles. And we're still talking about it now because it's just such phenomenal research, and the implications of it we need to take back and implement solutions within our communities. So this is going to be the difficult part, because we're going to be going through the questions that are part of this measure. It's 10 different questions. They're difficult questions. You can take this questionnaire for yourself, or don't. We're not sharing our answers, we're not sharing our scores, but just you are aware of what the questions are. So these are the results. And I want to talk a little bit about the demographics of the people that took this study, that were in this study. They were middle class, most of them were Caucasian, and most of them had some college education. And even in that group, we can see that about 36% of them had no adverse childhood experience, but the majority, right, 64% had at least one. So what they extrapolated from this study is that about a third of adults do have an ACE score of 0, and that the most adults with an ACE score of 0 do not have the risk factors for the diseases that are common causes of death in the US. Now, if you have an ACE score of 4 or more, it results in having multiple risk factors for the common diseases and causes of death in the US. Now, an ACE score of 6 or more results in a 20-year decrease in life expectancy. So I really wanted to connect, when we sometimes hear about research and studies, it feels very foreign, right? Oh, it was, an organization in California with the Centers for Disease Control. So I really wanted to bring it to, show you local data, to really show you that, hey, you know what? We have ACEs right here. So this is why conversations like this are so important. So Support Incorporated is the behavioral health agency where I work. In a 90-day period between 11/1 and 1/31, we had 675 intakes. That means new patients. Every new patient gets an ACE score. Now, mind you, the clinicians do not formally ask every question just like it was written, but they do ask about those topics. They do ask about those exposures. So it's really key that you're not necessarily needing to be extremely formal, but you are finding out about that family's trauma history. And as you can see here, the ACE study results showed 36% of people had an ACE score of 0. For our children, it was only 19%. And as you can see here, a quarter of our children have an ACE score of 4 or more. So how is it that ACEs cause issues for us? What is it? Well, when the body is under stress, when our system is overloaded, there are internal changes that happen to us. One of those is hormone level changes. Cortisol and adrenaline go up when we are in fight or flight mode. So what happens when cortisol and adrenaline are up? We have elevated blood pressure, which eventually weakens the heart and our circulatory system. We have increased blood sugar, which is a risk for type 2 diabetes. We have bone mineral loss. Our muscles waste away. We have a disruptive immune system and inflammatory response. In addition, we can have disruptive brain architecture and function. So let's talk about immune system changes. So there can be thymus involution. So the thymus, we have a thymus gland that as we get older, it starts shrinking. And what does the thymus gland do? The thymus gland produces T cells. So T cells are the white blood cells that fight cancer, fight infection. When we have adverse childhood experiences in our history, that thymus involution is faster, it's more rapid. So therefore, we are less likely to have a strong immune system. There can also be spleen and lymph node atrophy. Again, spleen handles our red blood cells, our white blood cells, lymph nodes fight infection. There can also be telomere shortening. So telomeres are repeated patterns of DNA at the end of our chromosomes. Those repeated patterns of DNA actually protect our chromosomes. Those repeated patterns don't message anything, they just protect the parts of our chromosomes that do. And as we get older, it is inevitable that our telomeres will shorten, but when we have adverse childhood experiences, those telomeres shorten even more quickly. So if you Google ACEs, you are going to see a lot of these type of pyramids. So when there is a foundation of adverse childhood experiences, it's going to lead to disruptive neurodevelopment, social, emotional, and cognitive impairment. We're going to adopt some health risk behaviors because we're just trying to cope, right, with all that we're carrying around, all that baggage from our childhood. And that's going to then lead to disease, disability, and social problems, and eventually early death. So why is this? What is going on with our brain that we are so susceptible to all of these issues? Well, here is a perfect illustration. Typical development means the higher ordered thinking brain dominates. But when there is developmental trauma, when a brain is exposed to trauma, the brain that dominates is the survival brain. It's the fight or flight. It's that reptilian survival brain. It's that brain that is always on the lookout for the next enemy. We're always, ready to fight, ready to argue, ready to just poor impulse control overall, right? It's that hypervigilance. We are in a chronic stress state. So I don't think that there's any more, next slide. I don't think there's any better illustration to see just the difference. This is a 3-year-old child's brain. Normal is on your left. Brain exposed to extreme neglect is on your right. Clearly differences in size. Clearly higher ordered brain is underdeveloped. So again, you're gonna see problems with emotion, with self-regulation, problems with learning. So clearly the child that's been abused and has suffered extreme neglect is at a clear disadvantage as they get older. This is another illustration of the same thing, that the highlighted areas in the normal brain, that's just normal functioning, plenty of tissue there working. And as you can see on the right side, the brain of an abused person does not have the same lighted areas. So given that we're part of the Gaston Controlled Substances Coalition, I think it was really important to bring up that when children grow up in environments where parents use substances, they are going to be exposed to some experiences that put them at risk as they get older. Households can be chaotic, unpredictable, inconsistent. Children are always on edge. They don't know what to expect. They don't know which parent they're gonna get. They don't know if it's gonna be the sober parent, the parent that can connect, smile, hug. They don't know, they don't know if it's gonna be the parent that's angry, uses alcohol, is completely disconnected and emotionally detached. That's just a lot of uncertainty. And for any of us who've had substance use disorder in our families, you do know that there's a lot of secrecy involved with it, right? No one wants to talk about it. It's not something that's openly discussed. There's a lot of stigma and shame with it. And for a child, there could be a lot of self-blame and guilt. Like, children are quick to blame themselves when things are going wrong. So this next set of slides, you'll see that ACE score, the higher the ACE score, the more health risk behaviors. But you can put anything here: diabetes, blood pressure, cancer. It would all correlate. So how do we meet the challenge? We finally get to the good stuff, right? Because we want solutions. So caring communities can help reduce ACEs. That is why we have assembled the panel we have here tonight, because they represent the best of our community. And we are able to have this tremendous resource, and we need to use the tremendous resources that we have in our community to combat ACEs. The American Psychological Association defines resilience as the process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress, such as family and relationship problems, serious health problems, or workplace and financial stressors. As much as resilience involves bouncing back from these difficult experiences, it can also involve profound personal growth. So what do we need to do? There's 4 building blocks to resilience. We need to facilitate, we need to build, we need to provide, and we need to mobilize. So facilitating, this is the most important one. In multiple research studies, this has been found to be the most important thing to building resilience in a person. Facilitating supportive relationships. Despite high ACE scores, if there is a supportive, nurturing adult in a child's life who follows them through their childhood, it is going to protect them from ACEs, or from the consequences of ACEs, I should say. Building, we can build a sense of self-efficacy and perceived control. Remember, kids don't often have voice and choice, right? And let alone when they are in a chaotic household, how much is their voice heard? So a lot of the times, the things that we see manifest in people is because they're trying to exert control, because they don't know, they haven't had control their whole lives, right? No one has ever built them up to be self-efficacious. Providing, we need to provide opportunities to strengthen adaptive skills and self-regulatory capacities. We need to mobilize sources of faith, hope, and cultural traditions. You know, how many children have said, hey, Boys and Girls Club rescued me. Going to church, going to Awana, right? Getting picked up on the weekends, going to church camp or what have you. That saved me, right? Because it's for kids, it's that feeling of, hey, there's something different. It's not all like this. The resilience questionnaire, so I had to put this in here, because the same way that we went through the ACE questionnaire, we have to see what are our resilience factors. Because in our childhood, there's always hope. There have been some lights, despite how high your ACE score is. So this was developed not for research, but really for parenting education. And it was a group of clinicians, providers, pediatricians in Augusta, Maine, that put this questionnaire together, basing it off of the ACE research. This looks like, hey, this is just for kids, but honestly, we can do this too as adults. We can read, we can talk, we can engage in creative activities. We can free play, we can do puzzles, we can engage in movement, and we can do problem-solving activities. So those are all things that are bioprotective. They build resilience, right? Because we are able to succeed at them. We are able to succeed when we do creative activities. Free play, there's no rules to that, right? It's awesome. So we want to also foster self-regulation. Remember that upside down pyramid, right? The traumatic brain, the trauma brain development, and the lack of self-regulation. So we want to stay calm. We want to model self-regulation. We want to develop realistic expectations for ourselves and for the people around us. You know, this drawing here with the woman in the middle, that despite the chaos around her, she is centering herself. She is, you know, keeping it together. We want to provide structure, consistency. We want to have self-awareness, right? We know when we're going 0 to 60, right? We know it. We feel it. It's, you know, it could be a pounding in the head, a pounding of our heart, sweaty palms, whatever it is. Know how to bring yourself back and regulate. You have to develop a toolbox of coping strategies. So what can we put in that coping strategy toolbox? We can take mental breaks, a book, music, coloring, hobbies, physical break, exercise, dance, sports, stretching. We can take a spiritual break, yoga, meditation, mantras. We can have a sensory experience. We can perform a grounding activity, slow counting, visual imagery, deep breathing, and it's not hard to find these things. Just open YouTube. You will find what you need to ground yourself, calm yourself, meditate. All of those things are at your fingertips. Positive self-talk, affirmations. What do you say to yourself every morning? How do you start your day? Social support, ask for help, connect with a friend, connect with a parent, connect with a loved one, just connect. And what else can we do? We can mobilize community resources. That's why we're having an event like this. Many community partners are involved, and we need to, you know, galvanize and really target adverse childhood experiences and being able to lower the effects of them. So schools, church, youth groups, the medical community, the Department of Social Services, trauma-focused therapies, and a plethora of other community organizations can be involved in this. Please tell us about ACEs and opioid use disorder in Gaston County.
Sure, thanks Dr. Melendez. Good evening, I'm Jeff Ellison. I'm a psychologist. I work with Contegra Health Services in Gastonia, and I'm a previous chair of the Gas and Controlled Substances Coalition. Again, I want to start by talking with you briefly about the state of the opioid epidemic here in Gaston County and really kind of across the country. As I'm sure that you know, nationally, opioids and opioid-related overdoses are a significant problem and remain a significant problem. In North Carolina, 2021 was the most deadly year ever for opioids and opioid-related overdoses. According to the North Carolina Department of Health and Human Services Opioid and Substance Abuse Data Dashboard, I'm only going to say that once, 2021 was had the highest number of drug overdose deaths on record in the state. And that is so that means over 3,000 North Carolinians died last year alone as a result of overdoses. So while those numbers technically include don't just include opioid overdose deaths, 95% of the the overdoses that were recorded in the database in 2021 involved illicit opioids, and that includes fentanyl and heroin and those sorts of drugs. And that leaves only 5% for other substances, including like methamphetamines and cocaine and benzodiazepine, Xanax, and those sorts of medications. So while overdose rates have been kind of on a consistent upward trend since the early 2000s, it's really taken an unprecedented spike in the last just couple of years. To put that in perspective, according to the dashboard, the data dashboard, in 2019, Gaston County, the rate of drug overdose-related ED visits was about 135 per 100,000 residents. By 2021, that rate had increased to 170 per 100,000 residents. So that works out, being that there are about 200,000 people, give or take, living in Gaston County, that works out to be about one person going to the emergency department every day for an overdose. And I think through working with the coalition, we know that number is actually a lot higher, because a lot of people that don't actually go to the emergency room for overdoses. So there's a lot of reasons behind these potential overdoses. The first is this increased availability of cheap and powerful opioids like fentanyl. Like I said earlier, in 2021, 95% of the overdose deaths were related to these really powerful opioids. But back in 2016, it was a whole different story. Only 50% of opioid deaths were related to these powerful opioids like fentanyl and heroin. And so the world has really changed as far as that's concerned over the past 5 years. So it went from half to almost all of overdoses are related to opioids. So, and really, these powerful substances like fentanyl are really concentrated. They're powerful, and even just small amounts can lead to deadly overdoses. And they can be mixed in with heroin. They can be mixed in also more recently. They're being mixed in with methamphetamine and cocaine and benzodiazepines, and especially with the people that are not using opioids and maybe not expecting these small doses of the fentanyl in there. Their bodies aren't ready and don't have the tolerance built up for opioids, and it's especially dangerous for those individuals. So this is one of the first reasons. I think the second reason, I think, goes without saying, is it's because of COVID. In North Carolina, in March, April, and May of 2020, and this is right after the stay-at-home orders were kind of put out, the total number of emergency department visits dropped by 40 to 50%. And so this is emergency department visits for stuff like chest pain and lacerations and broken arms. So half the people, there were a whole bunch of people not seeking medical care during that time. But in that same time period, that exact same time period, the number of overdose visits to the emergency room doubled. Well, actually, I'm sorry, it went up by 50%. It didn't double, but still, that's a significant amount. And that means that despite the fact that people weren't coming in for medical care, they were absolutely coming in a lot more for overdoses. So why is this? Why did more people start using substances in maladaptive ways during COVID? Oh, and I forgot to mention also, this trend was also noted with depression symptoms. This trend was noted also with alcohol use symptoms and other substances as well. So why did this happen during COVID and after COVID? Well, substance use has been linked, like Dr. Melendez was talking about, to a lot of different types of factors: depression, anxiety, stress, isolation, job loss of ability to engage in coping strategies. COVID caused all of those things. The last couple of years have been really hard. I think we can all agree with that. As Dr. Melendez talked about earlier, there's a lot of research that shows that individuals that have experienced trauma and have higher ACE scores have significantly higher chances than those that have not experienced trauma of having problems with substance use and IV drug use. Also, the way that people have experienced trauma can manage their risk for things like substance use is by being resilient. Like Dr. Melendez was saying, from the psychological perspective, resilience is this process of adapting in the face of adversity, in the face of trauma, in the face of tragedy, in the face of stress. So people that have high levels of resilience, that are able to adapt in difficult situations, are less likely to, for example, develop substance use problems. Or they're less likely, or they're more likely to develop a resilience so that they can recover. Unfortunately, the fallout from COVID has made it really difficult for a lot of people to be resilient in a lot of different ways in their lives. So on one hand, COVID caused more stress, right? A lot of people lost their jobs, their financial difficulties. They had to work from home. Their kids had to stay home from school, and you had to find childcare for them. They had to deal with their own illnesses, the illnesses of others, just all of these things just bombarding you, all these different types of stress bombarding you. And this is on top of all of the normal stresses of daily life. And for people with ACEs, on top of all of the stressors that are associated with all of those traumas and dealing with all of those traumas on a day-to-day basis, that's overwhelming. So on the other hand, it took away a lot of the things that we do that help people to be resilient. These are things like being with others. They're things like going to church, being with family, going to the gym, volunteering, even just things like going to the movies or watching sports, or certainly for kids, going to school. So these things disappeared for a lot of people for a lot of that time. So COVID caused stress, anxiety, depression, bereavement, and took away ways for people to cope and be resilient in the face of these stressors. So for people with ACEs, this is really, really a terrible combination, right? The safeguards that were previously preventing them from turning to substances to cope were gone. And this is likely, at least in part, the reason for this increase in overdoses related to ED visits in the months after COVID. That it's not just a problem for people with ACEs, it's not just a problem for people with ACEs or people with substance use difficulties. The impact of opioid use goes far beyond just those individuals. Their sons, their daughters, their mothers, their fathers, their coworkers, their church members, their community members, their next door neighbors. They're all vital community members, right? They're all people who struggle, whose struggles impact others. So an example of how this increases, how these increases in substance use and overdose have impacted our community is in 2019, half of the kids that were placed in foster care in Gaston County, and I got this from the data dashboard as well, were placed there due to parental substance use. And in 2021, so the total number of individuals that went into foster care in Gaston County increased significantly, but also that number jumped to 70%. So 70% of that even bigger number of kids that went into foster care was going into foster care because of substance use related issues. So there are more kids being placed, and a higher percentage of those kids are for substance use related reasons. So for kids in this situation, they're likely experiencing extreme stress at home as a result of having parents using substances. They've also been removed from their home and have likely been forced to change schools. They've likely, they're confused about what the future might bring for them. All of these things are cause toxic stress, and they're really the definition of adverse childhood experiences. So what happens is these kids go through difficult times, and just experiencing these things gives them ACEs. And the ACEs raise the probability that later in life they're going to have difficulties with things such as substance use and all kinds of chronic diseases. And the cycle is going to start again. So when we factor, so when we factor all these general stressors that kids have experienced through COVID, the loss of loved ones, being out of school, being away from friends, this generation of kids really seems like they're going to be at high risk for ACEs as they get older. Unless we can help them with resilience now, unless we can and figure out ways to prevent them from acquiring additional ACEs. So hopefully with the experience that we've got here, we can kind of, and the insight that we have in this room, we're going to be able to have a good conversation tonight about how we might be able to start with prevention and start teaching and instilling resilience in our community.
So first, I'd like to thank our 7 panelists for joining us this evening. We're going to begin the question and answer portion of our program by asking that you introduce yourselves and your respective organizations. We're going to start with Mr. Mayo. If you'd be so kind to start us off with your introduction, and if you could include a brief intro to prevention, which I know is a particular topic of interest for you.
Yes, I am a prevention pusher. My name is Maceo Mayo. I am Prevention Services Coordinator for RHA Health Services in Gaston and Rutherford counties. I am a prevention pusher. What do I mean by that? Dr. Melendez and Dr. Ellison have eloquently described ACEs. I like to get out in front of anything that's self-destructive and socially destructive when it comes to our young people. My responses this evening will be prevention-oriented, will be died and laid to the side prevention. So I'd like to share my definition of prevention with you so that when you hear me talk about prevention, you won't say, what are you talking about? I'm talking about prevention. So prevention is a proactive process that empowers individuals, communities, and systems to meet challenges of life, events, and transitions by creating and reinforcing healthy behaviors. Proactive process empowers. 2 very powerful words. Proactive means, to me, to initiate an action or an intervention assertively, intentionally, upfront, and personal. Prevention, I've been in the field of prevention, by the way, for the past years, and I've been in the field since 1973. The field has really grown. There are evidence-based programs, practices, and strategies that help to build resiliency in our young people. What's very interesting in Dr. Melendez, everything I was going to say she said, but I figured that anyway. Risk factors associated with ACEs are the same risk factors associated with, get this, substance abuse, teen pregnancy, teen suicide, gang involvement, spiritual bankruptcy, lack of attachment to schools, poor communication skills, lack of attachment to families and communities. So what prevention says is we would like to build resiliency. There are evidence-based programs that we have done in Gaston County for anti-bullying, for substance abuse, for parenting skills. These are programs that have proven to be effective and work if done with fidelity, which means do it the way the developers say it needs to be done. So individual resilience, we can say, involves behaviors, thoughts, and actions that promote personal well-being and mental health. And it refers to people, like you both said, it refers to people who withstand, adapt to, and recover from adversity. So I can keep talking all night. So I'll pass the microphone along. So when you hear me respond to a question, it will be prevention-based.
Well, good evening, everyone, and thank you so much for having me this evening. My name is Judith Ayala, and my part is going to be pretty much from the faith-based standpoint. being born and growing up in church definitely has had an impact in my life. I thank you for sharing your score. I'm a 4 as well. So I think that just being able to share and see where we are, we're proven evidence that definitely there is hope. And also, I'm a mental health provider, so I can combine the two together and make a big impact when it comes to educating our community.
Thank you. My name is Carol DeWitt. I am employed by Western Carolina Industries, which is a member-based employers consortium. And I'm here tonight to speak on the part of employers and what employers are trying to do, excuse me, to partner with their employees, to engage their employees and to support their employees so that they provide a work environment that allows their employees to transform their lives, to build resilience, and to partner with their employees as they meet life's challenges.
My name's Tina Peterson. I'm the Director of Social Work for Gastonia County Schools, so I supervise all 32 school social workers that cover our 55 schools. I am also the homeless liaison for the district, so I help in identifying students that meet that federal definition of homelessness, tracking data for the district that gets reported to the state, ensuring that students who are experiencing homelessness, their rights are upheld. I am also the foster care point of contact for the district. So when students initially come into DSS custody or experience a change in foster care placements, I am a point of contact for the Department of Social Services and help with educational stability of the student. I am also the person that manages the adult docket for truancy court. So when parents have been charged with school attendance law violation, I manage that. And my filter this evening will be focusing on providing a safe and positive school climate, and also the totality of the child, meeting the whole need of the child. They're not just their academic, but their social, emotional, mental, and physical.
Good evening. I'm Dr. Akinji. I'm the physician administrator for the service line that is the behavioral health service line at Carolmont Regional Medical Center. I'm also a child and adolescent psychiatrist. So I'm on the other end of that, where we get adults and patients and kid patients coming in who are at the end of their rope. Individuals who are in a crisis, people coming in through the emergency room at their lowest point, children whose lives have been disrupted, families who are just not able to hold things together. And it is interesting that when people come in at that point in their lives, just being kind to them and trying to help them realize they're still human beings. We're still here to help and support you. There is resilience even within that crisis. Even within that person who seems to feel like they have nothing, there is something we can work with. And so we come from that end of things, trying to help people understand where their resilience is, what we can hold on to, giving them hope, helping them take that next step forward. It could take a few times. Nobody is perfect. But taking that first step in the right direction is what we try and do. I'm a big advocate for giving children a choice and a voice. It doesn't matter if it's peanut butter and jelly or Jell-O. We don't argue about it. Give the child something to own, something to say, I matter. And that is the building brick to something stronger. We work really hard with a lot of families just to improve resilience and link them to community resources. Thank you for having us. I think this is really timely, so thank you.
Good evening. I'm Heather Kaufman. I'm the program manager at the Lighthouse Children's Advocacy Center here in Gaston County. And as a Children's Advocacy Center, we serve child victims of physical and sexual abuse. And our tagline is a place of healing and hope. So as many people have said today, we really work with kids and families at a very high traumatic point in their life, but are there to kind of offer that roadmap and continue all of the resiliency that we've all talked about today.
What manifestations of childhood trauma / ACEs do you see in your work?
So having serving children whenever there is a current investigation or disclosure of childhood trauma, like I said, most commonly physical or sexual abuse. We see lots of different ways that can manifest itself, but our focus is really giving children a chance to safely and openly make that full disclosure and start their healing journey from there. So we have a story that I often tell. We had a little girl, brown hair, green eyes, walked in and kind of hid behind her parents and said, "I'm scared." By the end of the interview process and all of the work that we do to obtain that disclosure, she walked out and she said, "I just feel free." So giving children that chance to speak and then know that they have a safe place, people that are going to support them, support their family through the entire journey, offering the evidence-based treatment models, trauma-informed care that we've talked about today, but then also assisting the family through that entire journey of potential prosecution and ongoing services.
Thank you. From my perspective, oftentimes I find that trauma is not always very obvious to everybody. And so sometimes, especially if it's multi-generational, things have become so commonplace that people are just desensitized and don't even realize the impact of what they're doing to their kids. So, for instance, we might have someone come in through the emergency room who's self-cutting, and the parent may not even realize it. It may be brought to their attention by a teacher at school, by which point the child has already experienced so much stress in the home from whatever the parent is doing, or stress at school, such as bullying. And one of the things we find to be beneficial is during the course of our assessments and trying to engage families, we provide a lot of education, a lot of education. It's very family-centered, individual-centered, trying to look for strengths and building on those strengths, linking to resources. When we have to admit individuals, we're very clear on what we're trying to target, helping families understand it might be a step-by-step process, and being able to have some hope for the future by linking them to other resources.
In the role that I play in the district with homelessness itself can be a trauma. And sometimes it's more straightforward and it's a loss of income and an eviction, but sometimes it is domestic violence that forces the move, or it is a natural disaster. And even now we are preparing for refugees to come to the United States from Ukraine. In truancy court, we call it peeling back the layers, because the attendance issue is up here and there are underlying issues that are forcing that attendance up to the surface. And a lot of times we see substance abuse and mental health issues in the courtroom.
Just really, really quickly, I mean, I know we've been mostly talking about kids, but I work in the primary care environment. I work with kids all the way to adults, and I work with a lot of individuals with significant chronic disease and chronic pain, and all of these things. And you know, like you're saying earlier, like it gets really complicated, especially as with the multi-generational trauma, and as individuals get older and all of these stresses come in. So it's really hard to tell specifically like how the diabetes management concerns are related to trauma, but there are definitely links, and the way that we manage even those like the seemingly medical concerns is a really important thing whenever we're addressing trauma. So doing not just behavioral health care, but also medical care in a very trauma-informed way is an important thing.
How would someone know that a person does have ACEs? What are kind of some of the clues?
So what I wrote on my page here is, you don't know. I don't know if that was the right answer or not, but you don't. I mean, you can't just look at somebody and tell that they have ACEs. I mean, I think that, and looking at your statistics, the statistics you showed, only a third of the population doesn't have ACEs, and that's in the statistics a while ago. In your organization, that was only 20%, less than 20%. Mm-hmm. So, I guess, in some ways, it doesn't even matter. We have to treat everybody as if they have ACEs. And so really kind of changing the mindset from identifying individuals with ACEs to just providing trauma-informed care in general. I know that didn't answer your question, but I think that's...
Yeah, no, that's great.
Definitely, I completely agree with that. A lot of times, it's hard to tell. People may come, and they may have other issues, maybe relationship issues with a partner or parenting issues, and you don't know until you ask the right questions. And I think that at that point, they don't even know that that's happened. And I think Heather also said, everybody I think would agree that a lot of times talking about these things is kind of being pushed or desensitized, that nobody really sees the importance of addressing those issues. So definitely I think that asking the right questions and being able to take the time to give them that opportunity.
Prevention says that if you take young people at an early age, teach them communication skills, stress management, conflict resolution skills, anger management, very early in the game, that they will build, shrink wrap themselves in protective factors. So they will be least likely to engage in any self-destructive or socially destructive behavior. Not never will, but least likely. So if you practice a sport, you can become proficient at a sport if you practice long enough. You can become proficient as a human being if you are equipped with those kind of skills in your toolbox, so that as you grow older, you take these skills, you implement them, you become resilient. So teen pregnancy, teen suicide, substance use, gang involvement, truancy, are all behind. We're doing things up front. So there are evidence-based programs that we are, sounds like a shameless plug, that we are doing at a recreation center, an anti-bullying curriculum called Second Step. We are also doing a safe dating evidence-based program called Safe Dates. So there are evidence-based programs that have proven to work, like Dr. Ellison said. It matters what happens at the end, but if you do your work at the beginning, the work at the end may not be as bad, if that makes sense.
Thank you so much for that. Now, at our respective organizations, what I'd like us to talk a little bit about is what resources are available to us to not only tackle someone with a trauma history, but how about if someone is currently suffering active trauma? What resources do we have available to us to help our colleagues, to help employees, our students? What resources are available?
From the employer's perspective, obviously some of the recent legislation that has ensured that employees have access to mental health care along with regular health care is great for the employer side. Also, an employee assistance program is beneficial to help our employees to make sure that they have the opportunity to seek counseling, therapy, and to strengthen themselves during the employment process. So those are two things that employers use to help their employees in the workforce.
How often employees do use that employee assistance program? I know it's available in several companies and everything, but any statistics around that? Like historically, how often do people use it?
Statistically, I'm not comfortable at giving number statistics, but I can tell you from being on the side of human resources and dealing with employees that it is something that as long as the company makes an employee feel comfortable using it, employees will reach out for it. But it's also very much handled a separate part of the employment process to protect the employee's privacy and to help the employee be comfortable reaching out for it. So oftentimes our employees use an employee assistance program more than we recognize. And often they'll come to us and tell us how much they were helped by one thing or another when they reached out to an EAP. But employers do try to keep it a separate process so that it protects the employee's confidentiality and makes them more comfortable reaching for help.
So yeah, I work for Contegra Health Services, and we are primarily a primary care-based organization, and so we see individuals for just general medical care. We also have behavioral health services and other kinds of services as well, but so we get the opportunity to see lots of folks coming through our doors, because most everybody goes to the primary care provider at least once a year, if not multiple times a year. And so one of the things that we do is we screen all of our patients that come through for depression and anxiety and other behavioral health concerns, as well as just kind of the chronic diseases as well. And so if anybody kind of screens positively on those, and you were asking earlier about the types of things that we look for with ACEs, certainly, depression and anxiety and just mental health concerns kind of cue us in. And we have behavioral health providers available on site at our primary care locations that go, and so we're able to go in during the patient's medical appointment and talk to the patient. And potentially get them connected up with care. And then once they are in our care, or involved in our counseling services or psychiatric services or substance use services, then we go through kind of a full assessment around ACEs, so that we can really kind of target their treatment a little bit more.
In the school system, every school has a school counselor, and the larger the school, more counselors. Every school has a nurse, school social worker to deal with crises. We have district mental health clinicians that are not assigned to the schools specifically, but are there as a resource to support and consult with. Every school has a school-based therapist provided by a local mental health agency, and all staff are trained in trauma-informed care and suicide referral protocols and in mental health issues.
There's never enough resources out there, but it's good to put it out. The Gateway also is a great resource. While they may not have the services themselves, they have the connections in the community, and it's just as easy as reaching out to them, and someone calls them back, finds out whatever it is so that they can connect them. And so I know that they have served a lot of people in our community, whether it is mental health services that they needed, and they were able to compensate some of those sessions, or if they needed food, or if they needed clothing, if they needed some type of support for their family, or they were homeless. I mean, pretty much anything that will be a good starting point, I would think.
Let's talk a little bit and shift a little bit to ACEs and COVID. Dr. Ellison, you really gave a great talk on why folks with high ACE scores have suffered so much during these 2 years of COVID. How do we come out of that? What are some ideas about coming out of that as the masks are lifting, hopefully, and hopefully there's no new variants and things like that? How do we slowly emerge, and how do we help folks that have worsened during this period?
One of the things that we have to do, and again, prevention is proactive. So we do needs assessments. We want to find out what's going on with people. And our work is data-driven. So if we find that people are suffering, or kids are suffering from self-esteem, they have begun to experiment with drugs a little more at a certain age level, we will do a needs assessment, either self-report, look at the YRBS, the Youth Risk Behavior Survey, Pride Survey, and different surveys that each MCO does, I think, every 2 years. If you look at the data that you have, you can match your data up with your evidence-based programs, practices, and policies, and implement those programs. So I think during the COVID period, as you said, people have begun to engage more in self-destructive behaviors. So I think one of the first things we need to do is to collect new data about how COVID has affected people in different arenas.
Yeah, I know in my work, we do mostly outpatient care, med management, and also leading several mental health teams. It's about building those reserves back up again. I think those reserves have been depleted, even for folks whose maybe anxiety or depression had never really affected their functioning. During COVID, they talked about the behavioral health surge. I really felt it was just an unmasking of what was always already there. It's just we had never asked the right questions. And, that extra pressure point really, showed us that we are very fragile. And I think that's the scary part for most of us when we learn our own fragility, right? And COVID came in and showed us that it was not discriminatory, right? It didn't. It came in and showed us the fragility of life. And we were in a meeting just today where they had reviewed the number of deaths in the last 5 years. And at one point, and I can't specifically remember the month, there was a 93% increase during this COVID time, a 93% increase of deaths in Gaston County compared to the previous 5 years. So that is a tremendous impact on families, on caregivers, children who have lost a caregiver, right? So I think that in itself is an adverse childhood experience that we're gonna have to figure out how to come out of.
Yeah, and kind of to add to that, I think during the whole pandemic, especially the shutdown and schools being virtual and all of these things, reporting of child abuse and neglect went so down because kids weren't able to have access or people to see, whether they'd had food or if they had marks or bruises or didn't have that safe space to go disclose any type of abuse or neglect to. So obviously, all of the reporting went down, but actually February of this year at the Lighthouse, we saw over 60 children, and that's more children than we have ever served in a month since we've opened over 6 years ago. So I think kids are just now finding those safe adults and are continuing to kind of peel off the layers, as you said, of all of the things that have happened throughout the pandemic.
And I think these issues that have manifested themselves have definitely affected employers, and they have caused employers to start looking at what they can do to be more approachable and more accommodating to the employee. Many of them are looking at the difference between becoming an employer that takes a transformative relationship with their employees, providing an environment that allows their employees to transform their lives and work through these problems, versus an older style employment relationship where there's more conformity that was required, more integration into an employee's life on the part of the employer instead of distancing in order to help address these problems.
So I'd like to take the last 10 to 15 minutes, because I think that one of the things that we need to discuss is how do we really get to the place where we build community resilience and we improve the lives of the people we serve and the people we work with. So remember, resilience, the ability to overcome serious hardship, right? That's a very small definition, but it's powerful. So I'd like everybody to start talking a little bit about how do we build individual and community resilience, and think about at each of our respective organizations if money was not an issue. What would we like to see? What have you thought about as you've experienced this time of COVID, as you've seen the repercussions of worsening mental health outcomes? What has crossed your mind?
I think the first thing starts with what we're doing tonight. Education, particularly in an employer and a workplace environment, and educating from the top down, educating the stakeholders of the business what this is about and the effects it has on people's lives and, as a result, on the business, educating the leaders in the business, the decision makers, and the people who are responsible for carrying out those decisions. Getting businesses to decide, make a conscious decision, what type of organization are we going to be? Are we going to be that transformative organization that provides that environment that our employees can actually transform their lives while working for us? Or are we going to be more of an organization that conforms to what's happened in the past? There are three kind of principles that we look at when we talk to businesses about what type of business do you really want to be. And one of them is this transformation versus conformity. The other one is doing what's right for the employee versus doing what's easy. And this is where helping employees build resilience and supporting employees in their lives becomes very important from the employer standpoint. But not just things like providing insurance. The law actually now mandates that we provide mental health insurance for our employees just like we do for other things. So those are the easier things. Providing an employee assistance program. You write checks for those things. Writing checks may hurt your pocket, but those are easy. But instead, some of the more difficult driving decisions that employers need to make concerning what types of policies and procedures and practices more importantly, practices do they engage in that actually support that employee and provide that employee with the support and services they need. So there is a what's right versus what's easy decision businesses need to make, and that's more at the forefront today in supporting these employees than it's ever been in the past. And then the third thing is, I think when we look at the concept of work-life balance, we've talked about that for years now, and that became so evident in the COVID situation where employers had to determine what are we going to do to allow employees to balance what's going on in their lives and their families and their children with what we need them to be doing at work. But even when you think about the concept of work-life balance, you really are thinking about two separate entities, work and life, that you're pitting against each other, saying somehow we have to figure out how these two things that are in conflict with each other can balance. But instead, I would challenge us to think about work-life integration, because from a standpoint of when businesses start to look at work-life integration versus work-life balance, they begin to understand and realize that they are a part of that employee's life. And in order to provide that support, in order to help our communities, we actually have to consider that we are integrated into their life, not trying to balance with outside of it. So I think those are three important factors that businesses have to address today, more so than they have had to do in the past. And they have to look at those factors as they make decisions on what type of policies we'll have, what type of practices we have. And those have to go all the way back to how do we hire people, the opportunities that we give people, because we find people on the outside of prevention. We find people that have lived through this and now are either being challenged with it every day or trying to turn their lives around. So how are we going to support them as a business through our policies, our practices, and sometimes our dollars that provide these programs that can help them build resilience?
I also want to say from, the organization that I represent, I feel like definitely there used to be a time when we felt like the biopsychosocial model will be the one that we're addressing everything, which each person biologically, psychologically, and socially. But now I know that there is a fourth component to it, which is the spiritual. So it's biopsychosocial spiritual. And so I feel like if within our own areas where we are actually functioning, if we're even addressing the trauma that is happening within our organizations. We cannot forget about the religious trauma. We cannot forget about the racial trauma that is going on as well. And so instead of causing more trauma, how can we help in building up trust with the people that are coming to us to seek help? Because sometimes we can see that within our own organizations. Can people really access services, access support where we are, or will they encounter more trauma whenever they come to us? So I think that is also important for us to self-reflect on what we're doing as an organization and if we're really contributing to the solution to the problem rather than actually adding more to that.
What would be the response to the number crunchers? To say it costs too much money to do that? Like, that are worried about the bottom line.
So you put the work, you do the work up front so you won't suffer the consequences later in the future. For me, I think I need to answer the last question. I need to be aware of my resilience or lack of resilience, number one. Two, we need more of these not town halls, but kitchen table discussions like we're having tonight. And the way prevention is going, there's 6 strategies in prevention. I'm not gonna mention them all, but there are 3 important strategies that we have really clung to recently, and that's prevention education. I think I mentioned that with evidence-based curriculum. And there is also what we call environmental approaches, where we try to change policies with businesses not smoking in public. But the third one I think is very important, is the reason and how we got here tonight is by joining coalitions, stop becoming so siloed and focus on our own goals, but to find within those concentric circles where we connect, to set short, medium, and long-term goals, to build resilience, not only in individuals, but within communities and community settings. I think the Gas and Controlled Substances Coalition is an ideal way. It is a model for how coalitions can work to change communities and change individuals, because the approach is not an individual approach, it is a comprehensive approach. It is everyone sitting up here and some more people as well. So I'll stop.
Just one comment about the investment part of it. I would say to most employers who are asking that question, the reverse side of that is, what are you going to do if you don't address these issues? Because what you do, the money you spend, the dollars you spend, this is an investment. It's an investment in your employee from the standpoint of what's right, but it's also an investment in your business, because that employee is the most expensive and the most important asset your business has. So if that business is going to thrive, you're going to have to make those investments in your people in order to make that happen.
In hearing you kind of talk about the employees, or just kind of the way, I guess I was thinking about myself as an employee in my organization. I was thinking of my wife as an employee, as a teacher, and how burnt out I've personally gotten in the mental health care field, how burnt out my colleagues across the hall in the medical side have gotten, how burnt out my wife and her colleagues have gotten. And we're the ones that are providing that care for the kids and the adults that are suffering the consequences for all of this stuff, all of the things that are going on during COVID. And so I guess for whatever reason, it hadn't really crossed my mind how important what you're talking about is in making sure that we're up to par and that we're getting the things that we need so that we can provide what we. Yeah, absolutely. So the resilience starts at the bottom. Like it's a chain. It just kind of works its way up.
So Dr. Akinji, because you are at the top of a very important resource here in the county, the healthcare system, the large multidisciplinary healthcare system. What would be your wish list?
I have a really long wish list. But I think the most important thing is we have to realize that we have to work together. money is a resource that is very tight. Prevention is key. And I believe that by the time we are seeing people in our offices as mental health providers, something has already failed because they're not coming to us because they're at their best. And oftentimes I'll see kids and I'll realize that the kid might be the identified patient for whatever reason, but there's a lot of sickness within the family that requires a lot of intervention. Education is key. Addressing stigma, very important, because people live with stigmas around mental health and will not seek care. And we live in silence and we have secrecy around things that are going on that are damaging lives. One of the things we've done at Claremont is we have some therapists embedded in primary care and some of the pediatric and family practices. The goal being warm handoffs, also being able to say, hey, I have a therapist down the hallway. This is not a scary person down the street. This is someone right here. And we intend to continue to grow that within the community just to ensure there's greater access. Training is important, making sure our mental health providers are aware of what they should be asking or not asking, aware of how they can handle situations so they're not traumatizing people, aware what could be triggering individuals. Sometimes we're not always aware, and it's a training issue. So just more trauma-informed providers would be key. On my inpatient unit, for instance, I have a sensory room. And so one of the things I teach my staff is everybody who is yelling no and screaming is not oppositional. They could be scared. They could be overwhelmed. And one of the key things I say to the kids is this door opens from the inside. You come out whenever you want. This is a fun place. It's quiet. We have chalk walls and people write all kinds of beautiful messages to each other on those chalk walls. It was one of the first things I implemented when I started. Huge chalk walls, and the kids express themselves. And we have all these affirmative sayings on the wall. You are important. You are good. You are kind. You are loved. Simple things like that that make a huge difference. We teach parents that they have skills. And I tell my staff, yes, this might be a difficult parent sometimes, but the parent is trying their best. If you look at it from the perspective of they want to do the best they can, then you have more compassion because we all get fatigued. Compassion burnout is real. And being able to look at folks and say, your history is driving some of these symptoms is crucial to being compassionate, culturally sensitive providers. So as you see, my list is long. But definitely, I think there's a lot of work to be done. And it's great that we're all coming together, and I hope we can do more of this. Thank you.